Thanks, Eric. Good afternoon. It's a pleasure to be here. I'm going to tell you a little bit about frailty, but in order to do that, I just want to pick up from what Eric said, which is that we have, as you heard this morning from Laura, we have created longer lives. And the next question, I believe, a critical question, as Eric was saying, is how do we create health and well-being throughout those longer lives, and what would the societal good be for that? Because, as we'll hear later today, it will, I think, with health, unlock the potential, the enormous potential and opportunity for society that we're getting to live longer. Now, when I was in training a few years after that Jim Freeze article was published, the arguments that I heard were whether cardiovascular disease was inevitable with aging and was actually part of the aging process. We've peeled that back a fair amount over the years, and we can now see that cardiovascular diseases are preventable, even while aging continues, although there may be some interplay. And then we can start thinking about aging itself. And one of the things we haven't touched on today yet is the force of life, if you will. What is it that creates real well-being? What is this elusive concept of resilience and reserves that gets bandied about as an essence that we might want to bottle and drink from over time? Well, I'd like to think about resilience, but perhaps by tackling what I have come to believe is its converse, physically and physiologically, which is the concept of frailty. Now, geriatric medicine was really created in large part with the treatment of frail older adults as its centerpiece. And with a concern to prevent both frailty itself and the poor outcomes that frail older adults were highly at risk for clinically. In fact, 7 years ago, in a conversation I had with Bob Butler, who of course was the founding director of the National Institute on Aging, he said, you know, frailty and cognition are the two major adverse health outcomes of getting older. So today we're talking about them together. But it's only 2 years ago, in 2013, that there was an international consensus conference that came to the conclusion that frailty itself is a newly recognized but long-standing medical syndrome. So what does that mean? Well, the definition that we have over the years created is that frailty is a syndrome of vulnerability to adverse outcomes due to the dysregulation of multiple physiologic systems. Now that's pretty nondescript, but let's just pull it apart a little bit. What's the definition of a medical syndrome? A constellation of symptoms and signs that cohere, and in their coherence, actually, the multiplicity of them point to a distinct pathophysiology. And I think that is what we have learned we're talking about here. But how on earth does this apply to frailty? Well, I encourage you to close your eyes for 2 seconds and see if you can picture someone who's frail. Raise your hand if you can picture someone who's frail. Yeah. Well, if I ask the same question in a nursing home, the same number of hands go up, and I've done it many times. So obviously there is a phenotype that we can identify. And in fact, fast forward after several decades of science, what do we know about this syndrome? Well, probably just what you have in your mind is very relevant as the clinical phenotype of frailty. We know that there is a constellation of diagnosable, recognizable factors of weakness, muscle weakness, slowness, cutting back on activity, low energy and exhaustion, and in the end stages, weight loss, that together, in a constellation, actually identify an underlying specific pathophysiology and predict adverse outcomes. So it's clinically recognizable, it's diagnosable, there's a recognizable phenotype, and it is important because not only is it prevalent, so about 7% of long-term care dependent older adults are frail by this definition, and the rates rise to about 25% or more in people who are in their 80s and older. And it's important because it does, in fact, just as geriatricians always thought, predict bad outcomes. High 3-year mortality rates when it's severe, risk of nursing home admission, risk of disability and progression of loss of independence, risk of falls, and in particular marks people who are very vulnerable in the face of stressors. So if you, at this point we know, for example, from Marty McCarry's work, that if you screen people older adults prior to elective surgery and they are frail, they are the group at highest risk of poor postoperative outcomes by a variety of measures. So it's prevalent. There's a definable natural history. It's chronic and it's progressive. And interestingly, when it is apparent, it is highly predicted by a unique pathophysiology. And that unique pathophysiology is multi-system physiologic dysregulation, which around a number of systems, including chronic low-grade inflammation, sarcopenia, as Eric said, hormonal abnormalities. And they occur in a nonlinear way, so that the more systems are dysregulated, the more likely you are to be frail. This is consistent, I don't have time to talk about it, but it's consistent with actually the emergent property of a dysregulated, complex, dynamical, adaptive system, which is essential to the maintenance of resilience and homeostatic capabilities in the face of stressors. And we have shown over the years that, in fact, if you do something as simple as a glucose tolerance test in older women who are frail compared to non-frail, that they all look the same in terms of fasting glucose. These are women who are not diabetic, but after 160 and 120 minutes, what you see is extreme dysregulation of glucose response in the frail and delayed return to normal compared to the non-frail. So why do we care about all this? For a variety of reasons. One is that I believe that what we're getting insight into are a lot of the dynamics of resilience and recovery and the ability to maintain homeostasis. We also, at every level of the syndrome, what seems to be driving all of this are energetics, dysregulated energetics, and in fact there's mounting evidence that mitochondrial abnormalities are driving every single one of these dysregulated systems to some degree in terms of production of energy. There may be many other biologic drivers, but this is the one we're starting to get insight into. The other thing is that many studies have tried to intervene with monotherapies like estrogen replacement therapy for frailty, and they have uniformly been unsuccessful. Understanding frailty as a multi-system problem suggests why that might have been so, and suggests the need to think therapeutically very differently. And a key to that may well be this whole interest in physical activity, which turns out to upregulate every single system that is abnormal to our knowledge to date in frailty, and like tuning up a car, and may provide a lot of insight into the potential for prevention. I'll stop there. Thank you very much.
Thank you. Very good.